I'm Whitney.
And I'm Kayla.
And this is our case study project.
Yes. Okay, so our patient is Eric. He is 27 years old and he is a construction foreman at Turner Construction. He enjoys evening jogs and dancing his nights away. When Eric came to our clinic, his primary complaint was intense right heel pain with no MOI, but it was a gradual onset. He described his pain as most severe during his first few steps after prolonged inactivity, such as after sleeping or after just sitting for long periods of time, and it was pretty severe at the end of his long work day. His pain is worsened by walking barefoot on hard surfaces and walking up the stairs or when he's climbing ladders or things like that during work, and his symptoms are relieved when he elevates his foot or when he ices it.
Plantar fasciitis is a common musculoskeletal disorder of the foot that is thought to be a result from chronic overloads and repetitive stresses. It commonly causes a person sharp stabbing pain that usually occurs in the mornings within the first steps taken because we sleep with our feet slightly plantar flexed. Plantar fasciitis is very common in runners or those with excessive pronation, pes planus or pes cavus, inadequate shoes, overweight, or a tight gastroc-soleus complex. Plantar fasciitis involves the inflammation of the thick band of tissue that runs across the bottom of your foot that connects your calcaneus to your distal phalanges. The average length of your plantar fascia is averaged from about 12 centimeters in length and about 2 to 6 centimeters in width. This band is divided into a thicker central portion and a thinner medial and lateral bands. As it approaches the metatarsal heads, the fascia divides into a superficial and deep layer. Together with the intrinsic foot muscles, the fascia stabilizes the arches and provides a dynamic sensory and motor control to the foot.
So a couple concerns we have with Eric is that he's a construction worker, so he is on his feet all day long. He enjoys running, dancing, and just generally being active. We also are concerned that he has excessive pronation and pes planus, which are both common with plantar fasciitis. And he's also, after talking to him and doing a physical exam, we found out he is unwilling to spend money on more expensive shoes and footwear for both his job and for running and different activities that would help relieve some of the pain he has with plantar fasciitis. Some precautions we want to take for him are to make sure he is taking both NSAIDs and icing after jogging or dancing or things like that. We also want to recommend splinting, especially at night. Heel lifts are an option. We could also incorporate some orthotics if he's willing. Possible injections, but we do want to be careful with that since injections sometimes can lead to a rupture of the plantar fascia. Again, discuss with him the proper footwear necessary for his job and his activities, and we want to strengthen both intrinsic and extrinsic muscles, starting with the intrinsic ones.
There are two ways you can treat plantar fasciitis, either operative or non-operative, but physicians are always going to require the patient to start conservatively and see how that goes at first. Conservative treatment will last for 12 months, and then the patient may be considered for surgery. Other non-operative things you can do are address proper footwear at work and during running for Eric, different training surfaces he's running on, and maybe try treadmills or turf or something soft, and also the biomechanics of his running and the way he is working. We can also again offer splints, heel lifts, and maybe orthotics if he's willing to purchase them. We will strengthen intrinsic and extrinsic muscles, and we'll also stretch and work on flexibility and range of motion of his ankle. The operative procedure would be a surgical procedure that is dictated by the severity of the plantar fasciitis and if there's a possible nerve entrapment as well. There's a couple different surgeries that are an option to do. An open medial plantar fasciotomy shows better results than a total fasciotomy or an endoscopic partial fasciotomy. Another option would be to lengthen the Achilles tendon. Always with surgery, you have the possibility of an infection and you have to maintain proper wound care. You also have to allot for time taken off work, issues with anesthesia, and just time being down and out from surgery. Depending on the type of surgery done, the patient will possibly not be non-weight bearing for up to 3 weeks, maybe less. They could possibly be in a boot or a walking cast. They will also not be able to probably run or jump for at least 3 months. Things that can be done for both would be some modalities: icing the foot or doing an ice massage, performing Grasson techniques on the fascia, iontophoresis or ultrasound, myofascial release, doing injections, but again, taking the precautions that could lead to a full rupture, or doing NSAIDs and ibuprofen to help decrease the inflammation and decrease the pain. In phase 1, which is the inflammatory phase, our patient Eric is going to decrease pain, maintain conditioning levels, and protect the injured area from excessive stresses. Modalities that we can use in this phase would be ultrasound and ice. Some exercises we're going to work on is doing towel pulls to work inversion, eversion, plantar flexion, and dorsiflexion stretches, marble pickups to work the intrinsic musculature of his foot, ABCs in the pool for range of motion, and some seat stretch to do inversion, eversion, and dorsiflexion stretches.
There we go.
So if you have a pool available, we would have our patient get in the pool, and we're going to perform some ABCs. Water will give a little extra resistance, and this will help the patient work on some range of motion. You can also make shapes. You could do numbers, draw their favorite object, whatever your patient would like that keeps them interested.
In phase 2, the repair phase, we're going to look at increasing and improving Eric's flexibility and range of motion. Upon inspection, we noticed that his dorsiflexion was decreased, so we're going to want to increase that, and we're also going to want to look at his gait and make sure he is ambulating without a limp. Modalities we're going to use in this phase are going to be cross-friction massage, Graston, and ice after treatments. Exercises we're going to be doing are TheraBand range of motion for early strength gains, the BAPS board and the wobble board to improve his range of motion, standing calf stretch, and also some toe raises to work his anterior tibialis. In this phase, we're going to want Eric to have full range of motion, so we're going to have him get on the wobble board, and he's going to just put his toes to the ground and then his heels to the ground and go back and forth, working plantar flexion, dorsiflexion, getting a little stretch in there. We could also have Eric turn to the side and do that same motion going side to side, like so. Okay, so for this phase, we're going to have Eric work on early strength gains. So he's going to put his table band in the frame of a door or around a table or a chair at home or something like this. We're going to have him go in and out, working on his inversion and eversion. So he'll do it one way and then he'll scoot around to the other side. And that's how he'll work the other side. We're also going to have him work his plantar flexion, dorsiflexion, that same type of way. So he would grab the band, get a little plantar flexion. Okay, so if your patient is too strong for the yellow TheraBand, then we're going to use the red one. So you would have them wrap it around the bottom of their foot to resist some plantar flexion and work on that. And then for dorsiflexion, you would go back to where the TheraBand is wrapped around a table or something, put it in their foot, and do resisting dorsiflexion.
In phase 3, which is a light repair phase, our patient is going to increase strength and endurance, demonstrate full range of motion, and work on proprioception skills. The modalities that we'll use here is ice after treatment if needed. Exercises will be trampoline work as he will march on the trampoline and go from a double leg to a single leg balance. He'll get on the bike and pedal forward and backward, do some squats to strengthen the whole leg, and calf raises on a step to eccentrically work the gastroc. All right, so to work on some strength and balance, we're going to have the patient get on the trampoline and perform some marching. And specifically, to work on balance, we're going to have him start with the double leg stance. If this is too easy, we can add a TheraBand around them and work on some rhythmic stabilization, pulling them all different ways, not allowing them to hold on. Then we can also progress to a single leg stance, doing eyes open, eyes closed to add in some proprioception, or they can eye track, so follow your eyes with the stick. Ready, it's on.
In phase 4, the remodeling phase, we're going to be primarily concerned with getting Eric back to activity pain-free and also his jaw pain-free. We're trying to return him to pre-injury levels. So in this phase, we're going to want to replicate construction work by demonstrating pain-free ladder climbs, and we're also going to want to be able to clear him for full activity by demonstrating jogging 1 mile pain-free, since he likes to do that at nighttime. Exercises we're going to be doing are jogging on a treadmill, ball toss with a single leg stance on the Bosu ball, and clockwork lunges and practicing reaching for objects to replicate something he would do on the construction site. We're not going to be using modalities for this phase because he'll probably be bored of them. Okay, so this is phase 4, so it's going to be our more aggressive phase. So we're going to have Eric first fast walking on a treadmill, and then we'll progress him to jogging. We can also do 30 seconds on of jogging, 30 seconds back to walking, or a minute on 30-second rest break, just depending on where his intensity level is and things like that.
All right, so this is our slide for the citation of the pictures, and this is the slide of the citations from where we got all the information about plantar fasciitis.
Hope you enjoyed our video.